Hello and good evening, good afternoon for some of you. What a wonderful privilege and a delight to host this first webinar. It is our first ever webinar that we're doing as FH Europe, and it is part of our annual network meeting, hence some of the branding that you might see. Normally, this session would have happened in our face-to-face meeting. However, due to COVID, we were unable to meet this year. And despite those challenges, there's something good actually, because we can bring more knowledge and more information to a wider community in the world. So with that, an absolute pleasure once again. It's an absolute pleasure as well to bring today to you top experts speaking tonight, connecting from the UK and Spain, representing the EAS FHSC, the Global FH Registry. So it's, as I said, a great pleasure to have with us today Dr. Alexander Lyons, Dr. Antonio Vallejo-Vaz, and Christoph Stevens from the Imperial College London. And I think some of you might be asking yourself why first ever webinar starts with a very, very specific topic of FH registry. As mentioned earlier, this particular content, this particular meeting would be happening in our annual, during our annual event. Again, thanks to technology, we're able to bring it to many of you spread around the world. I had an opportunity to actually listen to one of the presentations by Dr. Vallejo-Vaz the other day at the EAS Congress, and I realized how important this information is to the patient community, so that anyone who is impacted by FH can learn about the importance of the registries and how much the patient community can actually get out of it in terms of the latest research. And so with that, I thought for those who might be new for whatever reason to a wider topic of familial hypercholesterolemia, I think it's important to set the scene right. It's a huge public health challenge that we all as a community need to tackle. FH impacts 1 in about 250 persons. The latest research based on the latest meta-analysis shows that it's actually in some places 1 in 311 people, but it is agreed that we use one in 250. Based on those numbers, it's estimated that over 30 million people around the world are impacted directly by this inherited condition. What is really worrying that only 10% of people born with FH are diagnosed, which means that 90% of people born with FH are not diagnosed. Why is that? Why is the situation so terrible across the world? I think we all agree that first and foremost, lack of awareness and lack of understanding of this condition is the reason for low diagnosis numbers. However, there is another aspect to that. There is a certain stigma related to the condition and misunderstanding. And I think if we all understood the name of the condition, it would help us with our advocacy activities and efforts. It's very important to understand that familial hypercholesterolemia means it's inherited and it impacts not just an individual, but a whole family. It means that there is an excessive level of very important fat, cholesterol in the blood. Very often people misunderstand hypercholesterolemias, especially the familial ones, for they take it for the bad diets and bad lifestyle habits. Nothing further from the truth. Because this condition is so prevalent, we also have a rare form of it, the homozygous familial hypercholesterolemia, where a child can inherit the faulty genes from both parents. I wanted to highlight that because it's important that we all start from the same starting block. Having set the scene, I would like to share with everyone here who might not be very familiar with FH Europe as an organization, a few basic facts about our charity. The charity was created in 2015. The main mission is the advancement of health and the prevention of early cardiovascular disease, with a great focus, of course, on FH, but not only. Our advocacy scope covers as well, mentioned earlier, HoFH, but also other inherited lipid disorders like Lp(a) and FCS. As a network, we have 25 organizations from 24 countries. But there are also other countries that we collaborate with thanks to our partnership with Screen Pro FH. It's another organization within a wider FH community. And here you have a chance to see the territorial coverage of Screen Pro FH. Our charity also, beyond the collaboration with EAS FHSC and Screen Pro FH, is a member of the World Heart Federation, EURORDIS, the Rare Disease Organization, and FPIA Patient Think Tank. We also collaborate with a Global Heart Hub, International Atherosclerosis Society, Global Alliance for Patient Access, as well as European Society of Cardiology, International Lipid Expert Panel, and the European Patients Forum. Since this year, we are actively collaborating with the Global FH Advocacy Group brought together by the World Heart Federation. And as mentioned right from the start, we partner with the EAS FHSC, so the Global Registry. And that particular visual demonstrates the countries in green, dark green, where FH Europe has got members. In light green, those are the countries where there is already an existing registry. And hopefully, if there are any patient organizations, we will be happy to help and ready to help set those up. Or if there are already existing patient organizations, collaborate with those. The reason why I wanted to bring it up is to make sure that everyone who is joining today's webinar understands our organization, how we collaborate with the Global Registry. And with those fantastic speakers that we have with us tonight, I hope you will be able to understand a lot more what we together can do for overcoming the huge public health burden of lack of diagnosis of FH. Registry being one of the recommendations in the global call to action is definitely something we would love to ensure that our community both understands the benefits, but also actively participates. And with that, it is my great pleasure to give the virtual stage to Dr. Alex Lyons, who will explain the benefits and the organization of the Global Registry. Alex, over to you.
Thanks, Magda. Hello, everyone. My name is Alex of Imperial College London. Firstly, I can see some of our NLIs on the attendee list, so I want to thank you for your support by tuning into this meeting. The presentation that you're about to see by me will be delivered pre-recorded for technical reasons. Thank you. Hello, and welcome to the session entitled Global FH Registry, a collaborative approach to better understand your inherited condition at the FH Europe annual meeting of 2020. We at the FHSC are grateful to our collaborators, FH Europe, for being given the opportunity to deliver this session today. About us. I am Alex. I am a Research Associate Project Manager at the EAS FHSC Coordinating Centre with 4 of my colleagues based at Imperial College London. The EAS FHSC stands for the European Atherosclerosis Society FH Studies Collaboration. This was formally launched during the 83rd EAS Congress in 2015. The EAS FHSC also includes an international academic panel of 10 experts forming the executive committee, together with 83 national lead investigators forming the steering committee. Overall, we are a worldwide network of investigators and clinicians, all with an interest in FH. Our global reach spans 68 countries today, coloured in both red and orange on the map. Those countries yet to be highlighted, we wish to have on board, but are currently seeking the appropriate person to appoint as the national lead investigator and join our network. Our work aims to empower the medical and global communities to seek changes in countries and organisations regarding how FH is detected and managed, with a view to promoting early diagnosis and more effective treatment of this condition. Our work is registered as an observational study on clinicaltrials.gov. If you were to visit this website and type in the ID that you see on the screen, and then you will reach a detailed profile of our work. We also issue 4 quarterly newsletters per year, which contain the latest news from the EAS FHSC on FH, such as our project updates, publications, and various events. The newsletter is circulated to the EAS membership, FH Europe, and other various collaborators. We are very grateful to the FH Europe Chief Executive for her ongoing contributions to the newsletter. Our work began with the publication of an article entitled FH, the Global Call to Arms in Atherosclerosis 2015. The focus of the paper was a global call to action to address the existing gaps in care and reduce the global burden of FH, including employing early detection and effective treatment, increasing awareness, disseminating information, and promoting education among healthcare providers, policymakers, and patients, and to shape and develop the most effective healthcare policy on FH by establishing priorities and short and long-term goals and implementing and evaluating models of care, and to generate high quality and reliable data on current clinical practice and policies and their consequences on health outcomes, demonstrating the gaps in existing levels of healthcare and geographical inequalities. The initiatives to address the global burden of FH include, but are not limited to, both professional and patient organisations have initiated programmes to address the aforementioned gaps in care on a national and occasionally an international level. These include examples such as screening programmes, educational and awareness activities, consensus statements, or accessibility to therapies. Given the urgency to address the current challenges and need for large-scale information on the best evidence-based care and policies, worldwide efforts have been integrated by the EAS FHSC, which is a consortium of major FH registries worldwide, aims to generate large-scale, robust data on how FH is detected and managed and the clinical implications thereof. aims to disseminate this information to empower the medical, global, and lay community to seek changes in their respective countries and organisations to improve care of FH patients and families. Among others, some of the key aims and objectives of the EAS FHSC include raising awareness and education with special focus on primary care providers, improving health policies, establishing networks among different regions, including patients and professional organisations, and accessibility to treatments. This diagram is also published in this paper. At the top, you will see the three domains: the burden of disease, underdiagnosis, and undertreatment. And in the middle, you will see the implementation domains, such as promoting diagnosis and screening early, the formation of registries, conducting research, increasing awareness and education, improving policies, and focusing on therapies. So our talks focus on the registries and the research domains. So clinical registries in general are databases of patient-specific health information, and analysis of registry data may serve multiple purposes, such as epidemiological, etiological, and health outcomes research, assessment of healthcare protocol discrepancies between institutions, treatment efficacy assessments, and to examine cost effectiveness of treatment. Registry data may therefore be useful to perhaps patients, definitely practitioners, researchers, and policymakers by providing information on areas where healthcare can be improved. For clinical registries to be successful, patients and control volunteers participate in registries and provide their informed consent, usually at clinical visits. Robust registry databases are dependent on the submission of accurate and current information that meets minimal data collection standards. To start with, good quality data needs to be representative of the study population. It needs to be submitted to a well-designed registry which will contain a representative sample size. That means that the registry includes enough patients to be representative of the wider population. And then with the data, conducting appropriate analyses of the registry data to answer meaningful scientific inquiries. And that will therefore help inform care and guide improvements in care. Lastly, the implementation of secure data capture and management systems. There are softwares that already exist to build registries. Other registries and software developers may design the software from scratch. With clinical registries specifically, the EAS FHSC initiative, which is published in the Atherosclerosis Supplements 2016, the reference is at the bottom, aims to integrate efforts across the world to tackle the global burden of FH. Global FH Registry provides a large data set of cross-national, robust information that will help narrow gaps in knowledge, inform the medical community about real-world and best practices, assist in clinical trials design, and support clinical guidelines and policy development. Ultimately, this aims to help prevent adverse outcomes and improve care of FH patients. The FHSC is supported by the European Atherosclerosis Society. We have established collaboration with the HOFH International Clinical Collaboration HIC Registry to work on the homozygous FH population. And we have established collaboration with FHE Europe to provide talks and representatives at each other's meetings to share knowledge and to work on innovations such as findmylipidclinic.com that my colleague will talk to you about in the third talk. Thank you very much for your attention. My name is Alex, and I can be contacted at the email address on the screen. Thank you.
Yes, fantastic. Thank you so much. I wanted first to say thank you so much, Alex, for taking the time to walk us through and explain really to everyone what the EAS-FHSC registry is about and what sort of research and impact that particular global project brings to the community. I can see in our participants list, there's a lot of leaders of national patient organizations, and I know that they are very keen to understand how this particular registry can benefit their communities back in the countries, and I anticipate questions around that. Before we get to this Q&A session, I actually have a question to the participants right now through a poll. It would be really interesting to see who is joining us. So please help us understand if you join us representing patient community. You might be a patient or a carer or a parent, or maybe you're related with you collaborate with a patient organization, or you might be representing medical community. You might be a treating physician or a medical student, or if you represent the industry community, it would be as well interesting to understand who attends this particular webinar. And if you cannot identify yourself with any of those three groups, you can always select other. So over to you, Miguel.
Yes, please let us know if you can't see the poll. I see that 23 out of 34 participants have now voted. The panelists can also vote if they like, but it is absolutely not mandatory. And I would also ask, I see that there are 4 people that have voted for other, and we'd love to understand what other means. So if you don't mind adding your particular role in the chat, if you've clicked on other, we'd love to clarify that a little bit more. So I'm going to end the poll now so that everybody can see the results. But if you chose other, please add why you chose other in the chat so that we can see that. And you should be able to see the results on the screen now. We have 42% patient community, 8 people from the medical community, 31%, 3 identifying as part of the industry community at 12%, and we have those 4 others. So please take your time. We have John Reeve saying he's treasurer of FH Europe. So absolutely, John, that qualifies as an other. So thank you for clarifying that.
John, you represent the patient community for next poll. Wonderful. Thank you so much for sharing with us. And with that, it's my great pleasure to invite Dr. Antonio Javier Vallejo-Vaz, or Antonio, who will actually tell us as much as he can about all the latest outcomes and research the outcomes of the global registry. So over to you, Antonio.
We can see you well, Antonio. The virtual stage is yours, and we can see your slides well. Thank you.
Thank you very much. Well, thanks. First of all, I would like to give thanks to FH Europe for the invitation to participate in this session and present the FHSC registry. So my name is Dr. Antonio Vallejo Vaz. I'm the FHSE coordinator and chief scientist, and we are based at Imperial College London. As it has been previously mentioned in the prior talks, so there has been, FH represents a major public health concern. Earlier this year, a number of representatives from the global FH community produced this report and published this report, a global call to action, in order to try to reduce the health burden, the burden of familial hypercholesterolemia. There were a number of points that were discussed, but among them, it was as well the registries. So registries are an important way of research, and they can help quantify practices, identify the gaps that may be in knowledge or areas that require further research. Also, they give us metrics for monitoring and standardization, standardizing the care, and of course to characterize the FH population. While different registries have been initiated through the years in different regions or in different regions with different scopes, national, regional, local, etc., there has been tackling the global burden of FH has been limited by the lack of integrated approach between them, and so to maximize the exploitation of all the data available and conducting cross comparisons. With that idea in mind, it was launched the Familial Hypercholesterolemia Studies Collaboration, FHSC, during the EAS Congress in 2015, supported by the European Atherosclerosis Society. As it has been mentioned, the main aim of the FHSC is to establish an international and standardized registry of patients with FH, to maximize the exploitation of the data and generate large-scale and robust information on FH. In order to achieve that, we have to develop a novel platform, electronic platform, and FH data warehouse that would allow us to share the data and processing the data, standardizing them in order to be able to harmonize and pull all them together. Obviously, when data are available, we disseminate the information that we gain to an international audience, to ultimately aiming to inform clinical guidelines and health policies. And of course, the FHSC has allowed us as well to consolidate a wide network of investigators with an interest in FH. Since the project started in 2015, the number of lead investigators representing the country have been increasing progressively, and presently around 85 national lead investigators are part of the FHSC. The lead investigators, the national lead investigators are responsible for coordinating the FHSC activities and the local sites in the corresponding countries and regions. This has been shown before, but just to mention that, as it has been said, 68 investigators from 68 countries currently are involved in the FHSC. And if you are interested in knowing who are the national lead investigators in each country and even contact them, you can go through this website within the EAS website, and you can see the list there. So the FHSC, the methods of the FHSC has been published in detail in the study protocol, which is publicly available for transparency. So what are the kind of patients that are the people or participants that are included in the FHSC registry? So we included patients with a diagnosis of either heterozygous or homozygous FH, with a diagnosis either genetic or with a clinical diagnosis. This is with the combination of several clinical criteria, such as the cholesterol levels or having family or personal history of heart attacks, for example. And we also, where this information is available, we also include the information on unaffected relatives of FH individuals, since this can help us healthy control of patients with FH for the analysis and the studies. The data that is collected in the FHSC registry is non-identifiable for data regulation purposes. We include demographic data such as the age or the gender, how the FH patients have been diagnosed, what are the criteria, the medication that they are taking for lowering the cholesterol levels and other medication, clinical data such as, for example, if they also suffer from hypertension or diabetes, genetic information where this is available, laboratory tests such as the levels of cholesterol and triglycerides, and we also aim to follow the patients over time to monitor them and see how changes occurs over time and if there are events such as the development of cardiac conditions as well. So the data is collected locally, and they are through the national lead investigator merged into one national or regional data set that is then transferred to the coordinated center through the designated and secure FHSC web platform. The data is stored and processed in the coordinating center in the specifically created FH data warehouse and prepared for analysis and generation of reports. This is how the FHSC registry website looks like. It is restricted to investigators contributing to the FHSC registry, but the general FHSC website at the EAS is open to all. In order to merge all these heterogeneous data, because the data is coming from different sources and different formats, and for example, structures of different variables or information and how they are defined, etc., is different. So we need to work on finding a solution to merge all these local individual registries into one global registry. As a first step, we developed and we created a comprehensive data dictionary for registries of familial hypercholesterolemia that serves as the reference for standardizing or the information into standard or unique definitions. We also, in order to merge all these different data sets, and after checking the data, of course, we created and developed new IT applications and algorithms that allow us to map the data, validate the data, and then finally pull them into one unique, only FHSC registry. And finally, we also develop a data entry web application where patients can be entered individually instead of being shared as a full data set or registry. This facilitates the creation of patient registries for sites where this is not available. It's highly customizable. For example, the language where it is shown is time, cost, and resources to the investigators. And it facilitates the inclusion and the sharing of data in the FHSC website, since the data is automatically stored and standardized in a harmonized format in the registry. At present, this month, the number of patients the number of cases that have been included in the registry is over 63,500 individuals from 60 countries overall. The distribution from where the information is coming varies, and more cases are coming from the region of Europe. In this example that refers to adults with heterozygous FH, for example, we see that over 80% of cases are coming from Europe, but we have a representation from the other regions as well, and more data is expected to come. To have a full picture of what are the status of FH care in the countries involved in the FHSC, in 2018 we conducted among all the national lead investigators, as seen here, and also with the collaborators in all the investigators from these countries involved in the registry at that time, a survey of the status of FH in these countries. A total of 73 national investigators replied at that time, representing 63 countries. In that report, we summarized what are the FH-related initiatives in the different countries, involving, for example, what are the patient associations that are there, screening programs if they are available, what is the information like, for example, the prevalence of other data that is available. All this information is available through in this report that is publicly accessible. As an example, for instance, we assessed what was the most frequently diagnostic criteria that we are using in the different countries, and we found that in over 65% of the countries participated in the survey, the predominant criteria used was the Dutch Lipid Clinic network. It was also interesting to see that only in less than 10% the definition or the criteria for FH was tailored, adapted specifically to the population. So this is something that probably needs further attention. We also assess what was the availability of different therapies for FH. Remember, this was at the end of 2018. We observed that in all countries participating in the survey, the high-intensity statins were available. However, accessibility and reimbursement of the cost of them were not always the same in the countries. It varies considerably. Ezetimibe was available in most cases, but for example, at that time, novel drugs like PCSK9 inhibitors were limited to over 70% of cases and usually in a restricted use. Finally, lipoprotein apheresis, that is a similar process to the dialysis in patients with kidney diseases, but in this case, what we remove are the lipoproteins in blood that carries the cholesterol, was limited to 60% and usually centralized to one or only a few reference centers in the country. Another findings, for example, were that there was an important lack of information of data on the FH prevalence, so how many people in the country have the FH. There were overall low rates of FH identification in all regions, and there was variability in the management of FH cares, not only across countries, but frequently within the same countries as well. While genetic testing was often available, it was not widely implemented, and it happened the same with cascade screening programs. Treatment was common, and therapy was not universally reimbursed. So this highlights a number of gaps and points of interest that need to be assessed in order to reduce the burden of familial hypercholesterolemia. So from the data we already have in the FHSC registry, we are conducting some analysis in some subgroups and population of them with the aim to have soon, very soon reports and publications that help inform guidelines and health policies in FH. This is the case of the ongoing data analysis that we are conducting. It involves actually two populations right now. One is adults with probable and definite heterozygous FH that are being conducted in over 42,000 participants in the registry with this condition, and the other are children and adolescents. Actually, at present, almost 10,000 children included in the registry. So the analysis at present at the time of the entry in the registry, and we aim to characterize how the FH patient look like in terms of demographics, other diseases, the cholesterol, triglycerides, and other levels, lipid levels, and how FH is detected and managed by diagnostic in terms of diagnosis and identification, medication they are taking, and whether the recommended levels of cholesterol by the clinical guidelines are being attained or not. This is analyzed in the overall cohort by regions as well, by gender, and by other subgroups of interest. From some example of the preliminary findings that we have found in this analysis are that, as expected, there are some regional variations. This can reflect different factors like the population characteristics, the time of diagnosis, differences in screening programs, and it suggests that there is a need of individualized or tailored the programs and perhaps the diagnostic criteria, another aspect of the FH to the context, to the regional or geographical context as well. Despite being an inherited condition, FH is identified late, approximately in the 40s, and there are some gender differences as well. For example, women tend to be diagnosed late, but also they tend to have less prevalence of cardiovascular disease, for example. The rate of attainment of the cholesterol goals, so what are the cholesterol goals that these patients have on treatment, is poor in the sense that they do not achieve the low levels that are required. It improves when combination therapy is used, what suggests that probably in these people, in the majority of them, it is required combination therapy from the beginning, probably, but still the target attainment is low. And then the data also support the need for early screening and identification of these people and their relatives, because when these people are screened and they are identified younger and usually healthier as well, and with a bigger opportunity for the prevention of cardiovascular diseases in the future, such as heart attacks. So finally, looking ahead, so the FHSC registry remains active and it will keep receiving further data. We aim to expand the global reach of the FHSC to other countries as well. We keep working on the data processing and analysis in order to reply important scientific queries and produce research outputs that would allow to inform guidelines, health policies, and ultimately to improve the care of FH patients. Finally, I would also like to highlight that we work in partnership with FH Europe to promote awareness and early diagnosis and treatment of FH individuals. I would like to thank and acknowledge all the FHSC investigators that contribute to the FHSC network and registry, and thanks to whom this project is actually being conducted. Thank you very much, and I will be very happy to take any questions during the Q&A sessions. Thank you.
This is absolutely wonderful, Antonio. And it's the second time I'm seeing this presentation, and every time I have new questions for you. But this is a fantastic opportunity for all the people who joined to benefit from this very closed setup to ask any question to you. And I would definitely invite anyone to do so. I know that there are some countries who would love to leverage some of the findings for their advocacy and policy efforts. So we will definitely be digging into it. Before the question session at the end, I would like to already give you heads up, Antonio, and ask you, how can we both help your efforts as a community, as a network, because you have a lot of leaders of patient organizations on this webinar today, and also how can we benefit from all those findings, knowing that not everyone is a scientist, not everyone is a medic. How can we simplify some of the outcomes, some of the information and messages and calls to action that come as a result of the research? So I will park it and let you answer that later on. There are some questions coming through in the Q&A, so please keep going and keep making sure that you ask those questions. And in the meantime, it's my pleasure to bring the last speaker to the virtual stage, and it's Christoph Stevens joining us, and he will walk us through the latest project that we're doing together, the Find My Lipid Clinic portal. Over to you, Christoph.
Thank you very much, Magda, and thank you very much for giving me the opportunity to present findmylipidclinic.com. So this is a new initiative, and I hope you will like it. This will be a recorded presentation, as it was easier to do some demonstration, but do not hesitate to enter Q&A and enter some suggestion if you have some suggestion with respect to this initiative, so that we can still shape it in the best possible direction for patients worldwide. Hello, my name is Christoph Stevens, and I am a software engineer and data manager at the FHSC Connecting Center at Imperial College London. My work usually consists in developing functionalities for the FHSC registry that consists in data collection, anonymization, and harmonization of patient data. In this presentation, I will show you something quite different: a web-based worldwide directory of lipid clinic and patient support group called findmylipidclinic.com. Here is a screenshot of findmylipidclinic.com. As you can see, it is a website with embed, map, and search functionalities. The first functionality intends to help visitors find lipid clinic worldwide. The second functionality will help visitors find patient support group, also on a global scale. We notice that many individuals with dyslipidemia do not always find the appropriate level of care and support to identify, treat, and live with their condition. This website is our answer to help individuals with dyslipidemia find the right level of care and support they need. It is an initiative led by the ES-FHSC Coordinating Center and supported by FH Europe as part of our ongoing collaboration. The website will list all registered clinic and patient support groups that identify, treat, or support individuals with dyslipidemia. So this website is not restricted to any single dyslipidemia, such as familial hypercholesterolemia, polygenic hypercholesterolemia, familial combined hyperlipidemia, or FCS. We hope to reach individuals on a global scale, or at least in countries where we list patient support group and lipid clinics. Anyone is welcome to use the website, but we expect that most users will be individual and interested to find lipid clinic and patient support group. So the vast majority of users will be patients and their family member and clinician. Some other great online directory also help individuals find lipid clinic or patient support group, but we believe Find My Lipid Clinic is the first to list both patient support group and lipid clinic on a global scale. FindMyLipidClinic.com has 4 distinct features. The first features allow users to find registered lipid clinic worldwide based on a location and a radius, and filter clinic depending on the service they provide. Clinics can be filtered based on the following services: whether a clinic treats adults, children, or both, whether a clinic provides genetic testing or genetic counseling, whether a clinic provides screening of relatives, such as cascade screening, if a clinic proposes apheresis, either on-site or by referral, if a clinic proposes Lp(a) testing, if a clinic has imaging services such as computed tomography, angiography, echocardiography, ultrasound, and MRI. Finally, lipid clinic providing the service of a dietitian can be also filtered. The second feature allows visitors of the website to find support group by location and radius. So pretty much like the first feature, but to find patient support group instead of clinician and without filters. The third and fourth feature basically consist in providing information about FH Europe and the ES-FHSC. Here are 2 important points that we consider to increase the accessibility and privacy of FindMyLipidClinic.com. First, while the website is currently available in English only, we recently commissioned its translation into 28 other languages. These 28 languages, listed on slide, are spoken in many countries across all 5 continents. Therefore, by making the website available in these languages, we hope to reach more people and facilitate the use of the website. We also attached a particular importance to data privacy, and we decided that FindMyLipidClinic.com should not store any type of personal data from its visitor. We also decided to not use tracking cookies or any sorts, including Facebook Pixel and Google Analytics cookies. This completely means that our ability to monitor the website use is decreased, but the privacy of our visitor is respected. Some of you might wonder when this website should be used. In the current and next slide, I will describe two scenarios where the website might be useful. For the first scenario, imagine a patient living in Poland who was recently diagnosed with a genetic dyslipidemia. The patient rightly fears that his brother and nephews, who live in Belgium, might also have inherited the same condition and receive suboptimal level of care from non-specialists. Instead of resorting to numerous Google searches, the Polish patient used findmylipidclinic.com to search for lipid clinic that treat both children and adults. Instantly, the website returned a list of suitable lipid clinics where his brother and nephew can book an appointment. In our second scenario, a family member affected by genetic dyslipidemia would like to find a patient support group. On findmylipidclinic.com, the family can look for patient support group near them. Here, we chose Brussels. The website will display information about the group where they can find support, including the location, email address, and website if one is available. So here is the website, and you can see there are 3 different tabs. One for patient that contain 2 functionalities, find specialists, and find patient support group. The 2 other tabs are about ES-FHSC and about FH Europe. So first we can find specialists in Brussels, as in our first scenario. So I enter Brussels, a radius of 500 kilometers, and I would like to find lipid clinic that treat children and that have screening of relatives. I can now click on search, and all the clinics that are within 500 kilometers of Brussels are retrieved. Currently we only have 2 lipid clinics listed, and we plan to enroll more clinics and receive more clinics in the coming months. As we just started the website, we have relatively few clinics, and we are building on that and try to improve the websites. So these 2 clinics are in Belgium and in France, in Paris, and for each of these clinics you can find the service they provide, the specialty of the service provider, the website, the address, specialist name, and the institution. There is also a button to reveal contact details. So if you click on this button, the email address of the specialist will be displayed. This is to avoid spam, so that automated robot online do not send email to all the specialists. Similarly, you can look for patient support group, and this is done in the Find Patient Support Group tab. Sometimes you need to reapply the search, and then you retrieve the patient support group near Brussels. So you have the one in Belgium, in Brussels, you have one in Netherlands, in Den Haag, you have one in Reims, in France, and one in Germany, in Frankfurt. So patient can find both specialists and patient support group near their location. In the other tabs, you can find information about the FHSC. This is mostly for clinicians who would like to join and contribute with their patient data to the FHSC, or for patient support group who would like to join, or a patient who would like to collaborate with FH Europe. So this website will be translated into 28 languages and available also in English. And this should be automatically retrieved from your browser language, but you can always change. You will always be able to change in a different language using the drop-down icon on the upper right corner on the screen. I evocated earlier that Find My Lipid Clinic was in its early stage. As it is now, there are still many countries for which we do not have or have too few lipid clinics and no patient support group. We would gladly list more clinics, so if you are responsible of a clinic, then please contact us at esfhsc@imperial.ac.uk and you will send all the relevant documents and form. On the other hand, if you are responsible of a patient support group not already listed, please contact FH Europe or ourselves at esfhsc@imperial.ac.uk. We will gladly add your patient support group to the websites. Thank you very much for your attention, and I hope you will enjoy using findmylipidclinic.com.
Christoph, thank you so much for your presentation. I'm absolutely delighted that we were able to collaborate together as FH Europe and your organization. And I'm absolutely delighted to see how this project evolves with the contribution of different patient organizations and clinicians. I'm mindful of the time. We are absolutely spot on time. It's 7 o'clock, and I understand that there is plenty questions to be answered, and this is definitely a wonderful learning for future sessions that we will extend those to allow everyone to ask questions. There are few things that I just wanted to say. All the patient organizations that are already in the Find My Lipid Clinic portal have been automatically transferred from our network. So any new organization that will be joining our network will be automatically uploaded in the portal. However, I already had questions this morning from some of the patient organizations asking exactly how can they contribute. So wonderful to know that you have provided answer to that specific question. I would like to, before we go to Q&A, because I know that those who want to ask questions will stay, take the opportunity and quickly share my screen with upcoming webinars that we will have as a follow-up to this session. Please, for anyone who is still on the call, save your dates. In 2 weeks, on Wednesday, December the 2nd, we will have a continuation discussion directly led by current president of EAS, Professor Lale Togzogo, and past president, Professor Alberico Catapano, who will talk us through the latest medical updates for patients with genetic dyslipidemias. You will have in your chat links to register to that specific seminar webinar. It's going to be in 2 weeks, December 2nd, Wednesday, and we have already extended it by half an hour to ensure that we can answer any questions. And freshly confirmed only this morning, we will have another webinar in 4 weeks, as well on Wednesday, December 16th. COVID's impact on CVD patients community. Will the vaccine bring needed reassurance to our community? And the speakers will be Neil Johnson from the Global Heart Hub, as well as the CRE, which is one of the member organizations. Professor Meryl Kekicoglu from Turkey. She's also running a patient organization in Turkey. And Marius Geanta, our co-chair and trustee responsible for the medical and scientific group at FH Europe. So with that, you should be able now to see the links to register in the chat. And with that, I give the floor back to you if you would like to ask questions to our speakers. There's already one in the Q&A section, and that's from Marzena.
It's not really a question, but it's more of a comment from Marzena, saying that it's more of a user experience comment, saying that the default setup, saying patient organizations 500-kilometer radius around London, I think in her case, makes it a bit trickier. And she recommends that it would be better if there was a map, and if there was a map functionality to start off when landing on the page, and then you could narrow down your search further from there. So I think that the first initial part of the user experience was not as positive as she would have wanted. So I think this is a good comment for you, Christoph. I don't know if you have any thoughts on that, but I think it's a useful feedback for you.
Yeah, we try to have the location of the visitor picked up from the browser, but it might not work all the time, so I will have a look again. And then the radius is a bit small, so maybe for patient support group, we will extend the radius so that more patient support group will be localized. For specialists, we will have more specialists, I guess, within countries, so we didn't want to list too many, and also we don't want to have all the listed specialists retrieved by other websites. So we try to restrict the radius, especially for specialists. But for patient support group, we can definitely set a bigger radius. And yeah.
I think what could be helpful, and we've been already discussing it over summer, is to make sure that the patient community actually gets a real feel and a potential to test it hands-on, because a session like today is definitely a wonderful experience to see what's available, but you need to go and play with that to submit comments. And I think it's something that we would definitely pick up and do with the community. So let's take it offline and see how we can best facilitate that feedback session. Wonderful. Excellent. Thank you. There are some other questions I can see.
There's a question from JP Coring about he's looking to be put in contact with the developer, please. I don't know if that's you, Christoph, but
yeah, that's me. I'm doing it on an ongoing basis. So yeah, that's I think I can gladly be in contact with him.
We can definitely facilitate that communication and connection between our speakers. So JP, I'll be happy to jump in there.
Perfect. And just a comment from Jules, but I don't see any further questions in the Q&A section. So that can be an excellent sign. It means that the presentations were very, very clear and precise. So hopefully that is the case.
I think what is important for everyone's benefit who is joining today is to understand that we have recorded that session, and we will be doing our best to have them translated with transcript in as many languages as people might feel is needed to deliver it to their local communities in their local countries. I think it's extremely important to understand the benefit to the patient community of registries. And with that, Antonio, I would really like to hear your comments on my initial question.
Yeah, no, sorry, I was muted. So thanks very much. Yes, actually, I think that's a very important and critical question, actually. I think working together is right, a very good opportunity, because the aim of patient community and research community is the same. So it's ultimately improving the care of FH patients and increasing knowledge about FH, awareness, etc. And this can be better achieved if we go together through the different sites. So, and I think an example of that is the important report that was published on the global call to action earlier this year with representatives from the different stakeholders from the FH community, so patient organizations, researchers, and clinicians, etc., and from different world regions as well. So I think I can see, I mean, there are a number of important points, right? Probably one of them is the contribution in terms of dissemination. So any research output, so research makes sense if the results of the research reaches the population they are intended to. So writing papers and having there in a repository doesn't make sense. You need to reach the community and FH patients, relatives, etc. So in terms of dissemination, I think collaboration with FH Europe is critical. But and also another important point is not only that, but also that we can also have the views from the patients, how can they shape the research. So what is important for the patients? What really matters for them? So there is no disconnection between what research does and what patients are really interested in. So I think that that's critical. And in that sense, I think these kind of joint meetings are very, very important. And of course, if we try to put pressure or to inform policymakers, this is something that we need to go together. So because reaching from the different sides will put the phage in the agenda of the policymaker. There is no way of, we need to go all together. So I think collaborations is quite critical, actually.
You put a great smile on my face, and I hope there are big smiles on faces of all the listeners. As we speak now, the French patient community, Annette, and I can see actually on the list 3 representatives have joined. They are desperately trying to speak to their policymakers to improve the situation in terms of the child screening and family screening in France. The Polish patient organization, the president of the Polish patient organization, she is as well trying to advocate with her community, with the Polish authorities to lower the levels. And I'm embarrassed now because we discussed it only this morning in Polish and I forgot the English words for that. In any case, her attempt is to ensure that patients have better and quicker access to some of the treatments, the PCSK9 inhibitors, as well as the screening age is lowered. And I think this is an excellent example where all the findings and evidence that you collect on a global level can be put into good use on a local, national level for the benefit not only of patients, because those are people who have been identified, but also when creating health policies for the FH community who has not yet been diagnosed and identified, and that's extremely important. And I think it's okay to say that we've been already discussing that every research that's been done and every publication that's there, we need to get better at bringing that to the local level, whether it means simplifying the language and making sure that it's available in the local languages. So I almost sort of take that as our 2021 resolution to make that happen together with wonderful people at the FHSC community. Thank you so much, Antonio. Is there anything else, any other calls to action from your side to the patient community here today?
Yeah, so, well, just only to mention that we are conducting this main analysis from the registry and we expect to publish them soon. And I hope this will make an impact on characterizing how the phage care is currently doing and will help to put pressure on policymakers and put the phage in the focus of many of them. Because I think there is a lack of general awareness, not only in the general community, but even in the scientific and medical community as well. So I think this is important. Yeah.
Absolutely. Wonderful. Thank you so much. And Miguel, help me out. If there are no other questions, there is a comment. Yeah, go ahead.
There are a couple of comments in the Q&A. One from JP Corey. Has any other app web requirements gathering been undertaken? I don't know if there's something that we want to answer on this webinar or we want to take it offline with Christoph. I think what I will do
is happily connect Christoph with JP, and I understand the interest that JP has got because he's been recently involved in a health hack, and that's the benefit maybe to connect the learnings and experience. So we will do that.
And then there's just one comment or request from Mutaz. Says need and help of who to work under its umbrella in MENA.
So we're referring to specifically the Middle East region, Middle East and North Africa, and WHO. Mutaz, thank you so much for raising that. And I think as much as we're talking about the global registry, we understand that you represent the Iraqi community, MENA, the Middle East and North Africa. I think it would be definitely useful to have those conversations directly with Antonio and the team at the EAS FHSC at the Imperial College. If there are no further, gentlemen, last word maybe from you, Antonio, Christoph, Alex.
Yeah, so basically giving thanks for the opportunity to present the registry and to looking forward for this collaboration to go further ahead and having more joint meetings as well.
There is a request here from Meta in Denmark about patient support groups. Again, I'm not sure this is something we can answer directly on the webinar, but perhaps one for Magdalena to connect with to see regarding patient groups in Denmark.
Absolutely. And I am just so mindful of the time. And my personal timekeeper just came in and I could not have planned it better. Ladies and gentlemen, I will take the liberty to jot down all the questions that came through. Thank you so much for your words of support and for joining us. I look forward to having you all at our next webinar, and we will follow up via email with all of you. And for any questions, as Alex, Christoph, and Antonio share their email addresses, we will be happy to facilitate any conversations offline. So with that, thank you so much. And let's keep connected and let's make sure that we help our global and mostly European patient community. Thank you so much and have a lovely evening, everyone. Thank you.
Thank you. Thank you.